sickle cell trait, that would be accepted, or that would be approved, at least based on the information that I've had so far from our own ethics committee.
And would this be done on the NHS, or you have to
Yes.
do privately?
Yes, this is done on the NHS. It has to be done on a PGD licensed center.
Okay.
And when it comes to, this is a very rare scenario.
Yeah.
In cases like this, the couple should refer to a PGD center that would accept to transfer, for example, an embryo that is affected by a condition. Or they might wish to only transfer embryos that are unaffected from either condition. It depends on what the couple would want first.
Thank you so much.
Okay. Oh, sorry, she's going to apologise for having lost all the questions. She's not going to apologise. Never apologise.
My question's regarding the adult bone marrow transplant, and it was a bit more clarification on the heading increased risk of myelopathy.
So, meaning AMN, I think.
No, cerebral ALD.
Okay.
No. What again? No.
There was Professor Berg's heading regarding adult bone marrow transplant.
So I
So
think
it's talking about
meaning
the
that if
AMN
you've
worse
got
then.
AMN, your complications of bone marrow transplant are more. Yeah, Wolfgang knows about that.
It's more cerebral ALD.
No, isn't she?
Am I wrong?
You know, you were talking about how often the spinal disease deteriorates a bit and then sometimes recovers.
Yeah.
It was that way.
It was all, I've got spinal
myelopathy,
cord
isn't
circled as well, so I think it might be.
Well, we are talking about the first 14 patients, which are very heterogeneous in adult condition. And from these 14 patients, we are discussing some situations that may have a great impact on the outcome after transplantation. And one of the major impact is the neurological AMN situation, how severe it is before transplant. So it's only 14 patients, but from this first impression that we had, we're discussing in that paper, which is coming out soon right now, that the more severe patients are before transplant, the more complications we have after transplant, in terms of infections, in terms of complications with the treatment itself, and also in terms of progression of the disease itself. But so this resulting in a deterioration in most of the patients directly in the first 6 months after transplantation. So 12 of the 14 patients deteriorated, either motor-wise or was psycho syndrome, with cognitively. But then some of these patients getting better in the time thereafter. So after 1 year, we had quite a lot of patients that are stabilized, or only slightly worsening than before transplant, and they stopped with progression in the second year. So under the line, we learned from this situation in the first 14 patients. So we now selecting more carefully patients for transplant, and I can tell you that in the meantime we have transplanted in Berlin alone in one center 15 patients already, more with a better selection of the patients, not so severe affected before transplant and so on, and we got much better survival rate by then. So I think the important message is that there is a life-saving treatment also in adulthood cerebral ALD, which is bone marrow transplantation. I mean, I'm currently analyzing my patients, historical patients, without transplantation. So there are more than 50 patients with this condition in my group of patients with adulthood cerebral ALD, and I have a survival rate in these patients of 5.5%. 5.5%. So this is not a good situation. So bone marrow transplantation in adulthood is really life-saving. It's really a good advance in treatment. But we have to select the patients very carefully in terms to get good results after the transplantation. So our intention currently is now to bring people together worldwide, also from the UK and everywhere, and bring this experience, discuss this experience, and maybe we succeed to have a common protocol, a common strategy for the treatment of adulthood cerebral ALD.
Did that answer your question? Go on.
Current, to get right down to the nitty-gritty, really, current difficulties in walking, possibly not good afterwards. It's not really a question you can answer.
You mean, what does you mean?
So the bone marrow transplant isn't going to cure AMN.
No.
It's only for the ALD bit. So the AMN will be at least as bad as it was before you started,
Yes.
and there's a risk that it may get worse.
Yes, that was.
Oh, yeah, that's a good point. Just to make it clear again, the bone marrow transplantation is not a treatment for AMN. It's a treatment to stop inflammatory disease only. Only.
Hello, can I just mention I'm just going to go to the room next door to for the focus group. So if there's anyone interested in just having a quick flick through some documents to see if they're clear, that would be really helpful.
Layla, do you want to say a bit more about what focus groups
Just
are
in
about?
relation to
Documents.
Yeah. Carry on.
Go
So I
on.
just wanted to say a bit more about what the focus group's about. So, as I mentioned yesterday, it's to do with newborn screening and setting up in Bristol. So I'm making sure that to try and make sure that the test works. It would be helpful if I can get. I'm not looking to get consent from anyone today. It's so that when I'm applying to go through the ethics process and they're checking that my consent forms make sense and that the research that I'm doing is suitable, that they understand that people who I'm likely to be asking in the future have okayed the forms really. So that's more.
So this is asking people to give you blood spots to put through the...
It's about asking people with children under the age of 25, because we would still have those blood spots in storage that were collected when they were newborns, to retrieve those to see if the levels are high.
And you want people to look at your consent forms?
Yeah.
So you want people's experts' advice
Yeah.
as families
As
affected
families
by
affected, yeah.
whether they think the consent forms are correctly written and are clear.
Yeah, that's just right. Yeah.
And also there's a consent form for younger people as well, I think, is that right? One
Yeah,
for
so-
parents and one for younger people.
Yeah, so there's two consent forms. There's one for parents, and that could be for any children up to 25. For children between 16 and 25, if they have the capacity to make decisions about consent themselves, then there's ones that they can
And
give
you'd really
consent.
like to know if anything's unclear on the form, could
Yeah,
be written better.
exactly. Yeah, so I've got a few copies for people to look through. Thank you.
Really should be quite straightforward.
Just in relation to the adult BMT, what my understanding is we haven't had any in UK, and are there any plans afoot?
Okay, so I'll say something to that. There has been one done in the UK and it didn't go very well a number of years ago. We have a problem in the UK that although we have a National Health Service which has lots and lots of advantages, one of which is that we have national criteria for doing things like bone marrow transplantation to make sure that it's a resource that's being used appropriately. And so in paediatric bone marrow transplantation, a number of metabolic diseases, including ALD, have been approved indications for bone marrow transplantation for many years now. That is not the case for adult BMT, where it is nearly always done for hematological malignancy. I think it's probably done for some hemoglobinopathies as well, but mostly childhood probably. And that has been a problem. So although we can start doing scanning, we can try and pick up early cerebral ALD, we then have a major problem that I cannot phone my friendly local bone marrow transplant doctor and say, can we do a transplant here as quickly as possible, please? We would have to, recently we have done some work between the metabolic and bone marrow transplant groups within NHS England, and they've agreed to extend the indication for metabolic transplantations up to the age of 24. I don't know quite why they chose 24, but there you go. But that isn't really going to help us very much. So any bone marrow transplant we were to do would have to basically be done as an individual funding request. Now there are mechanisms for doing that. There are mechanisms for doing that urgently in inverted commas, but until we've done it, it's difficult to know how it will go. And one of the problems we have, and hopefully this will be made better once there's some publications, is that there is really not very much published about doing bone marrow transplantation in adults with AMN developing ALD. You have to provide evidence if you're asking to do these things, and at the moment, until there's publications, that evidence is missing. So we'd be very keen on, I think, the idea of working in order to come up with a set of guidelines that would say who you should and shouldn't. Transplant is a very good idea. We would then have to take them to NHS England, and it'll be different in Scotland, to NHS England and to probably the clinical reference groups, who are the people who give clinical advice to NHS England, and try and get those approved so that it would actually be an indication. And there would be a quick mechanism for making the diagnosis and getting them to a bone marrow transplant centre that could do it for them. That is something we're working on, but it's not going to happen tomorrow.
Well, we've made quite a lot of noise in NHS Lanarkshire. I don't know what's happened behind the scenes, but I think that...
Well, of course, unfortunately, Scottish and English NHSs are different, but I mean, they do talk to each other. I come to you.
In some ways, Scottish NHS tends to be a bit more sympathetic for individual treatment.
Individual funding.
I think that's happening.
Yeah.
Although I don't know the mechanisms, but we've certainly presented our case, and I think we would presume it's
Yeah, well, if they're more efficient about making a decision, that's good.
I was thinking in terms of adult bone marrow transplant, is there a possibility of doing it as a multi-centric trial involving UK and...
It's difficult to do that sort of thing as a clinical trial. You have registers, really. I think Colin probably knows more about that.
Yeah. There have been incredibly few trials ever done in bone marrow transplantation, and part of the problem is that no two people are alike, so somebody has a matched donor, somebody has a mismatched donor, somebody has a half-identical donor, so it's comparing apples and oranges straight away. And then there's always new drugs being developed and new methods of preventing graft versus host disease. And so it's very, very difficult in rare diseases to ever get enough patients together in a reasonable time frame that you can treat in a consistent fashion, and you've got no control arm except a historical control arm, which is never entirely fair because lots of treatments have changed in the different time zones, as it were. So it's difficult. This funding request issue will also be very, very difficult. They will fight hard against it. Whilst there's no published evidence, they'll say no. And it would be almost probably up to getting your MP to lobby for you to have a transplant. It would be that level of discussion required, I think. Although you can make independent funding requests, they are for extremely rare and unusual situations generally. If it's in a situation where this would be the first of potentially many, they regard that as what they call a cohort request, and they want you to justify why that cohort of people will need transplantation in the future, and they're even more tricky about accepting that level of evidence. Also, the level of the evidence will influence them. So if somebody says the survival after this procedure is 50%, that's actually high enough probably to make them look at it fairly. But if they said the level of survival is 80%, which Wolfgang is hoping that it might be more recently, that's much more persuasive. because that's good value for money in anybody's book.
I come back to it again.
So from memory, I'm going to ask a few questions on behalf of the lost questions. Okay, so this is kind of aimed at Mark and you, Robin, I suppose, really. So as you found out yesterday, we have a female carrier who's recently been tested positive for Addison's disease. She had a short snack and it was all, done properly. So now and in the future, can you see a need to test females for adrenal insufficiency?
I think so. You're dealing with two conditions. They're not so. Even two rare conditions aren't always related. So you certainly want to be looking for other causes of Addison's disease before.
She hasn't got any autoimmune condition.
No, but Hugo Moser looked at 3,500 carriers, and there were no Addison's cases in the 3,500. So it's very, very, very rare.
I don't think, I'm afraid, I'm not sure that we're not going to start routinely doing
follow
shots
too
and that.
advanced.
Do you? Okay, so yeah.
But if there are clinical reasons to do something, then
So if someone had symptoms which could indicate Addison's disease, then you would do the test.
did this person have a crisis?
No, she was one of the sort of unusual carriers in that her doctor in Oxford has been doing cortisol tests and short synaptin tests yearly for quite some time.
Mark, do you have anything to add to that?
No, just that very recently we had the same discussion in our clinic, because we had one woman with ALD who complained about some things that could be interpreted as symptoms of adrenal insufficiency. We decided to test her. We don't have results yet, but I think it's reasonable, and now that we know that it can happen, just to stay alert. And if people have complaints, I think it's reasonable to test them. But I don't think we should start testing them routinely, because it's probably rather wrong.
In almost anyone who came to you with symptoms suggestive of Addison's disease, you test them. So,
Is there not a problem with female testing for adrenal insufficiency? We get false negatives routinely.
From what sort of testing?
For the adrenal insufficiency.
So, I mean, if you do a Schultz-Nackman test, that's, I think, still, our endocrinologists have gone, but I believe that's pretty gold standard, really. So basically, you're giving the hormone that the brain produces to stimulate the adrenals, you give it a synthetic version, and then you make sure that the adrenals respond. Random cortisol and random ACTH are very difficult. You should try and do them at 9 a.m. in the morning, where there are good reference ranges. Very difficult for me to have all my patients sitting in clinic at 9 a.m. in the morning. I'm there.
Florian, did your patients come up on synaptin testing or just on random cortisol?
Well, both were symptomatic.
Yeah.
But in our experience, we actually don't routinely do ACTH stim tests. But we just test ACTH, and and our endocrinologists also seem fine with that. So over the course of the day. So and once it's above 300, we usually start keeping.
Yeah, but in addition, you frequently have a strange situation. They have most of the patients have high ACTH, but they're still responding on the synacane test. So it's not really adrenal insufficiency. Maybe there's some minor sensitivity of the adrenals to to normal ACTH. So in this situation, many patients don't have any clear symptoms of adrenal insufficiency, so we not treat them, but inform these patients that in certain stress situations they may use cortisol. So it's something in between. It's not the usual Addison's disease like in the autoimmune Addison's disease, which also reflected by the situation that AMN patients usually need lower doses of cortisol in my experience than the autoimmune patients.
We've seen that, and yes, so surgery and things you cover with a bit of hydrocortisone beforehand. I mean, the answer is it's not it's not entirely easy. But I don't think anyone's going to be screening routinely, but be very aware clinically that there might be a problem.
And one's assuming that females should manage their Addisons in exactly the same way as...
This female should manage her
Yeah.
Addisons. Right, yes. We don't want to be...
No, I know. Now this one's for Alistair. Picking on you then. So yesterday we heard a lot about you saying that drugs don't work for this, they don't work for that, they don't work for the next thing. And I'm sure there was plenty of people sitting in the audience thinking, but I just want to stop my child from being uncomfortable, I need to sleep, I've been there, I know exactly what they were thinking. So I know from experience that a lot of the drugs don't work and they just make confusion worse. But is there anything that if your child is appears to be in huge amounts of pain, say from muscle spasms, they've had baclofen, they've had, all that kind of... Is there anything that you would say would be kind of safe to use on the odd occasion just to actually give them a relief of that pain?
Thank you for that. A very good question. So obviously, just to be clear, the drugs do work, but not very well. So what they do is get the family out of the clinic room, because you would say, here's the prescription, and family go away. But actually, when they're at home, things are unlikely to be much better. So just to reiterate my key points, what does work well to help confusion and complex care is multidisciplinary, high-quality care, and being meticulous to pick up all the different triggers. But your specific question was around distress, and of course distress disrupts sleep. So in general, I normally go through a checklist of things with distress and poor sleeping, and I kick off with boredom and sleeping, and also seating and stretching of limbs and feeding, and after I've done that checklist and the bowels opening, and I've done that checklist and checked that all of that is optimal, then I will consider drugs. But unless someone tell me how they've done all those well, luckily in general these days we have very good multidisciplinary teams for children, so that normally is done pretty well these days. It wasn't 10 years ago, I think, but it is now. We'll then reconsider medication. As you mentioned, the good news is that quite a lot of the drugs we use to treat dystonia and spasticity also relax you and make you feel a little bit happier, maybe a little bit more sleepy. So baclofen, for example, and trihexyphenidae are two drugs that we use that will improve stiffness. The advantage of them is they improve the stiffness and might make you feel a bit more relaxed. The bad news is they can make you a little bit sleepy, and the sleepiness can make you more confused, so you have to be careful when you give them that the distress doesn't increase. Now, what we've had in the UK in paediatric practice is we've worked out that children, the wonderful series of hospices across the UK were developed, and there's a very good one in Cambridge, which the Duke Duchess of Cambridge is a frequent visitor to. And they were developed really for children with conditions, mainly oncological conditions, cancers, who were dying. But of course these days, children with cancers don't die in hospices, they die at home, surrounded by their family and community. So the hospices have morphed, have evolved into a different type of practice, which is often helping families dealing with very complex multidisciplinary care, in particular things like respite care. And they're great, and they're fantastic resources for many families who are dealing with complex conditions, and they now work in conjunction with community services and with my service and primary and secondary services, so it's all coming together quite nicely. But the rub is, my own experience is we're having a tsunami of children with complex multidisciplinary care who've been prescribed very strong drugs for chronic conditions, and the classic one is morphine. Now, morphine is a drug which we use for terminal care, and you use it for weeks, maybe months, but you can't use it for longer than that, because anyone who's been a heroin addict, like I have, sorry, Joe, will know that your dosage of morphine, the other name for it is heroin, you need to go up and up and up and up on it. So you get tolerant to it very quickly. So the gist of it is that some of the strong drugs for distress work only for a relatively short period if you give them regularly. So what I say to the families I deal with is, it's up to you. If you use these drugs regularly, you will have nothing up your arm for a real crisis, and I recommend you do. And most families find that really useful information and say to me, well, roughly what do you think is too much, what do you think is too little? And I generally say to them, about 3 or 4 times a month, you could have some special drugs, strong ones, that will help your child sleep or reduce the distress. And the 3 drugs we use that can be helpful, emergency sleep, is melatonin, the natural hormone we produce that stimulates you to go off to sleep but doesn't maintain sleep. The second drug we sometimes use in emergency is chloral hydrate on children, which is useful for both initiating sleep and can make them feel a bit more relaxed at times. And the third drug, which occasionally I find some people use, would be morphine. I'm rather biased. It's absolutely banned in my practice for using that as what we call a really terminal care pathway. And virtually no children with neurological diseases go on that because of the fact that it's too tempting, because it seems to solve everything, and then a week later the problems returns. You give a bit more and a bit more and a bit more, and it gets everybody into a horrible circle. And there are also governance issues. You know, Harold Shipman in Manchester, 270 old people were given morphine for good reasons and they all died. So I'm very nervous about that route. But there are things you can do for emergencies. I guess one simple message is, talk with people, get the team working and get them to brainstorm. Is that helpful?
Karen, could I just ask a slightly related question about control of secretions in someone with poor cough reflex?
That's a very good question. That's another thing that will make you very. If you're finding it difficult to control your secretions, there are things we can do to help that. Good positioning, good physiotherapy. So simple things first. Good sleeping in the right, correct position, all good. Checking people are swallowing. If you've got a difficult cough, swallow, you may get food down the wrong way and cough and splutter and produce more secretions. When you've done all that checklist, then you're allowed to go to your prescription list, and there are the little hyoscine patches that can go behind your ear, which I think about 1 in 2 children will tolerate or find beneficial. 1 in 2 children will either find it not beneficial or might get a bit of an allergic reaction around the patch, but they can be quite useful. They need a really sensible community-based paediatrician to advise, because we normally, for the little kids, you do 1/8 of a patch every 3 days, and for a big kid you might do a whole patch up to every couple of days. So a little bit of careful titrating on that. And the reason for that is that they have quite sedative side effects. It's the same patches used for seasickness, which will give you a rather dry mouth if you overdo it and make you rather sleepy. And again, we don't want. Sleepiness can be good and bad. Sleepiness in the middle of the night is good. Sleepiness in the middle of the day is normally bad. And there's an extra medication we can use called, a very long name, I can never spell it properly. Top marks if you can tell me how many R's there are in it.
3.
But again, that's a drug. It's really quite similar to the patch, and again, it's another drug, and we're trying not to get escalation of drugs and more complicated drug regimes, and some of the children will come in with 8 different drugs, and then there's a problem. I'm not sure what's doing what. So if I were to see someone every 6 months, or which I tend to with complex conditions, I always have a rule trying to cut off 1 drug every time. So it gives you some room for manoeuvre. But again, it needs to be titrated in quite carefully, but it can be extremely helpful, both the patches and the medication for some children.
Are you using Botox?
We do use Botox. We use Botox on many different places. So Botox is botulinum toxin injection, which if anyone's watched any celebrity programs, you'll know you have it in your face. But Robin is regularly going off for his afternoon session. He's top up today. But actually, it's enormously useful for stiffness in legs. and we find it very helpful. But what we do is we say, well, which bit's the problem? So an ambulant child who's on their tiptoes, we might just put a little bit of botulinum toxin in their calves, so it brings the heel down and allows them to walk normally. A child who's walking quite well, but knees are knocking because the stiffness is bringing the knees together, we might put a little bit of botulinum toxin in the adductors. Now, I've told you all the same message, I'm going to give it again. We don't think about drugs, we think about multidisciplinary care, because the Botox only works for 3 months. And we use those 3 months when the Botox relaxes to get seating, mobility, and that's physiotherapy, school, care workers, everything going, and get the legs a little bit better positioned, because it will return in 3 months' time. So Botox injections from an orthopedic surgeon in isolation generally don't work. Now I mentioned you can do it on the inside of the legs and the calves, but you can also do it on the salivary glands. My own experience is that, unfortunately, on the salivary glands, I find it's a relatively low rate of getting good symptomatic improvement. So I think it would definitely be the minority, but it's a very simple procedure, and it's something that should be available in every region. I think, Andrew, in Bristol, it's something that would be routinely available. Yeah, and you would probably be getting, if you're starting to need glycoporonium and to need Botox injections into the salivary gland, you're moving on from your local secondary community paediatrician to be the secondary lead in neurodisability, and often there's just one in each district, and at that point the child should not be under any paediatrician locally, it would be under the neurodisability lead.
Yeah, I was just going to make another couple of comments about that. I mean, trihexyphenidyl, which we sometimes use for dystonia, where the central control of tone is abnormal, can drive secretions a bit. But you get other problems with that. It slows the gut down, you're more likely to get urinary retention, the focusing doesn't become quite so good. So quite often there's a sort of trade-off with these things. And I agree with Alistair entirely. You don't want to rely too heavily on the medications, because you can get over-medicated quite dramatically. But all of these treatments are symptomatic or empirical. You try them out, see if they work, and if they don't work, take them back off. And quite often be aware of the sort of biases that can come into play when you just make changes when things are bad. When things are bad, they tend to get better. When they're better, they tend to get worse. There's a sort of mean effect. And if you always make changes to medications when things are bad, quite often you're fooled into thinking it's the medications that made it better, when it's just the course of events that make it better. So I think if you go into medicating, being aware that you've got to try the medications out, take them away at some point, try them again, see if the effect is consistent, that's helpful. And in some circumstances, not necessarily in ALD, because I don't have that much experience of it, but in some circumstances you get problems with tone that go along with problems of autonomic control. So you can get very panicky, high blood pressure, fast heart rate, and things like this. Paroxysmal autonomic instability with dystonia, we call it. And in those circumstances, there are some medications that can help stabilize things. And again, we're not quite sure how they work or why in absolute terms. But clonidine is one I would sometimes try, or gabapentin as well. So I think there are, if you are feeling things are getting desperately bad, there are things you can fall back on and try. But be aware of the bias of trying it and things getting better and assuming it's a medication that did that.
Okay, so we're going to have to. I've taken over from Karen again. So there was one more question Karen had about the IGD, about whether you test female embryos as well as male embryos. Yes is the answer to that. So as I said yesterday, they will harvest embryos, they will look for embryos that don't carry the gene, and then give you the best looking ones back, whether they're male or female. Right, I promised Jeff you could ask a question.
That was the you answered really. I asked Dr. Robin this morning whether we heard yesterday. I can't remember which doctor spoke about it, about a trial of a drug which is being conducted in mice currently. I can't remember who spoke about it. I was interested to know when the trial that's being done in mice might be transferred to humans. But Robin, I think you said that has already happened. Is already happening.
Florian was talking about gene therapy in mice. That isn't going to be happening for a while, I think.
Is it glyphosate?
The Pi glitter zone, I'm not sure anyone's really allowed to talk about this, but I think probably within the next 12 to 18 months there might be clinical trials started.
The video was not working with the mice. You see the mice yesterday.
Yes.
The video was not working. So
No, that's
well, in mice it's working, but mice are not humans. You know, this is kind of a problem. Yeah. Well, these are work from the Barcelona group. They're showing that ALD mice treated with pioglitazone, they can walk much better over the stick than without.
So there's a company in Barcelona called Minorix who are working towards getting that into the clinic.
Yeah.
I think I'm allowed to say that.
Could I just say quick words? I mean, there was a very good conference in Amsterdam about 3 weeks ago that I was at, and there was an awful lot of presentations on gene therapy for genetic and inborn errors of metabolism, metabolic disorders. And it seemed to me that the message from most of them was that gene therapy itself is something that's doable for most conditions, but probably was not going to be curative in isolation. That what they needed to learn is which populations within the disease itself would benefit from it, and which adjunctive treatments might be beneficial. And it's a little bit like the journey they've made with leukemia in childhood. When I was born, 1964, the death rate in acute lymphoblastic leukemia in childhood was something like 90% at 5 years. And the death rate in 2016 is something like 5%, 4% at 5 years, for even 2% for good prognostic ALL. But actually in that 50 years, there's been no one step that's made a huge shift. In fact, what they found was there was one thing that worked quite well, but then got worked for 10 or 15%, and then you put something else in and something else in, and each time it involved another randomized controlled trial. So it looks to me as though the gene therapy route for inborn errors of metabolism, for many of them may follow the same route, that you do your first trials and find actually it's not particularly effective, but it was out of the 10, only 2 got better. But hold on here, maybe it is good for just that subgroup, and then you can build and build. And why did it fail in those patients? Because something happened, or maybe we can reverse this with a drug. So the good news is there's an awful lot of work going on worldwide on gene therapy. The bad news is it is a very long way off treat for virtually any conditions other than the very rare immunodeficiencies which it's being used for at Great Ormond Street, where there is a stage when it's givable to the broad group of patients affected by a genetic disorder, and can work in isolation and will be effective for the majority.
So I agree with that. I think we want to do our animal studies and give them a certain proof of concept value, but we also want to look to human studies, and I think collectively we're going to learn in incremental steps, and it might be that we perform gene therapy in humans, and then we realize that there are additional targets that or goals that were not reached that require additional treatments. Pioglitazone has been used in hundreds, if not thousands, of human patients. So I think we actually have to be aware of looking at that data for other conditions it's been used. So let's just be clear about that. And I think what I look to that data mostly for is its safety. And I think as we move forward, we are always hoping for the best for patients, but we want to make sure that there are not adverse events that are occurring that we walk into blindly. So I think that's very important.
I think the problem with PIA is it doesn't get into the brain quite as well as it might do.
And then you can get peripheral nerve, right? And so I think there are other potential.
I did my PhD in gene therapy 20 years ago, and I'm very pleased I moved on to something else in the meantime.
We would love to hear your views on this, Professor Stewart. Our daughters both are obviously carriers. The pediatricians are divided on whether it would be beneficial to do an MRI or not. Perhaps for the elder one who is kind of showing some signs of AML, Pooja always says to me that she reminds him of his childhood, some of the symptoms, excessive tiredness, joint pains, joint instability, so frequent falls and things like that.
How old is she?
13.
13. Well, we've never looked at the girl. we've never done an MRI on a girl, is what I would say. But Robin, what do you think about that?
I'm not sure MRI would be necessarily the way forward anyway. I mean, it'd be very young, I think, for a girl carrier to present. I guess it's not impossible. I would have thought if there are clinical problems, I'd go down the route of seeing your GP and a neurologist. And there are probably electrophysiological testing you'd be doing rather than an MRI, I would have thought.
The local pediatrician referred to the Edinburgh, which is a more tertiary centre, to the second, and the pediatric neurologist and the pediatric metabolic consultant, you know, the neurologist doesn't think there is much value. I myself also didn't think there is much value, but the pediatric metabolic person said maybe a baseline would be useful.
So you're going to see it. I don't think it's going to help.
It's more at the baseline, but we don't know what it will add, other than just maybe find something incidental. And
I think the other thing is with MRIs, if you do them at an early stage, they can be incredibly difficult to interpret. And then you don't know whether you're better off with that knowledge or worse off. And I think you're often worse off.
Exactly.
And we're talking about AMN, not ALD. So
yeah.
we're talking about the spinal cord. I can't see. I think it wouldn't add anything.
Yeah.
She would require sedation.
Well, no, it should be fine. But
About 13. So she could not still.
And you would think electrophysiological studies would be more beneficial,
I think that's what we.
Well, they'd show you the functional problem in the nerves and the spinal cord,
Yeah.
which you might not pick up. You're raising your eyebrows at that one.
So the only girl that I found symptomatic who carried the gene had carried the ALD gene but had a completely different neurotransmitter defect. So I think it's actually better for you to have her be seen with a complete blind eye to the ALD part.
Probably by a neurologist, not a metabolic doctor. Right.
Hi. In a family that our family has had both men and women severely affected, but just from middle age, obviously neonatal testing would be brilliant, but can it revert to a CALD presentation if the rest of the family so far is just presented from...
So genotype-phenotype correlation, we call that. Is there a definite relationship between the mutation you carry and the clinical picture?
So I don't know if there's consensus here on this, but I'm going to say this, that there are about maybe just a handful of mutations for which we know that AMN only occurs. Okay, in terms of the occurrence of cerebral ALD, there is no genotype-phenotype correlation.
So in one family you can see almost every presentation. Wolfgang, would you agree with that?
Yeah.
Okay. So no, I think it's a simple one. Well, yeah, it depends what the question was. Could something else happen? Yes. So is it worth doing PIGD even though there's no one in the family with CA? Yes.
Yes.
Right, we are towards the end of our time. Are there any more burning questions? Does anyone feel that they were bad, so bad? Yes. Including us.
Well, a couple of questions really, and sort of related. I'm a great believer in patient power, as you probably know, and we've heard over the weekend of at least 2 trials, possibly 3 trials for AMN patients, which are, I think there's the one in Italy, and there's the biotin trial today. I would like to be able to inform patients about the existence of these trials, because patients can then talk to their clinicians wherever in the world they are and say, you know, can you tell me some more about that? And I think that's healthy for the whole picture. So where can we go to get details on these? And maybe Sarah will tell me that it's all going to be on the ALD website. But that's one question. The second question is just related to one of the basic problems with AMN patients is, of course, spasticity. One of the drugs that's sometimes talked about on Health Unlocked amnesia patient line is something called 4AP, but I never hear it prescribed in the UK. baclofen is the preferred drug. Can we say anything about the best approaches for spasticity?
Let's do spasticity first. What are we doing clinical trials? Which are you doing, Wolfgang?
The 4AP is approved for MS patients only for improving spastic gait. In MS it's called fampridine. I think it's the same here. We did a trial in AMN patients with 4AP, which is not fampridine. You can get this from a pharmacy and make the drug by yourself, but it's the same ingredients. So, in terms that fampridine is not approved, even in Germany, it's also not approved for AMN patients. I cannot prescribe it to AMN patients. So that's why we used the compound 4AP and put it into capsules, in the 5 milligram capsules, and made a trial, clinical trial, and got the same results like in MS patients. There are patients who respond on this treatment very good. So the improvement of walking is really dramatic good. Also, some patients improve with their bladder dysfunction. And there are other patients who are not improving, they're non-responders. So what you can do to talk to your doctor is that you can give it a try. If you're a responder, yes or no. And then you have to check if you can prescribe it. Can you prescribe it in the UK for AMN?
I don't think we can. Fampridine is quite expensive.
Yeah, it's expensive.
So the problem with fampridine, so there's nothing to stop you prescribing something off-label. We don't just have to use things for what they're licensed for, but when they're expensive, the NHS won't let you do it. So fampridine can only be used, I think, by MS specialists in MS. Then you run into the problems with, if there's another problem, could we get hold of 4AP and get our pharmacy to formulate it?
Yes.
Yeah, but you would get a lot of grief from the people who made fampridine, although you then go back and say to them, but I'm not using it in MS. So you might be able to get around it, and I guess if we thought it was going to help, we could persuade pharmacy. What they would then worry about is that the MS patients would start getting hold of the cheap stuff and not be using the licensed medication. So it's not entirely straightforward. Florian, do you want to add to that?
So we have similar experience in the US. I have a handful of patients who feel they've benefited from, and they are using the generic form of the drug. To come back to your earlier question, clinicaltrials.gov is probably the site where most trials are registered. And so I would say that's where we're all going to and referring to.
Right. But I think the problem with the MedA, the Viatin trial, was it was a limited number of patients. It was available from Paris and Berlin. We actually did send one patient who was keen to go in, actually originally was from France, went over and see. They filled it up quite quickly. So it wasn't really available to our patients.
There are only limited numbers of patients. There are one patient from California who was very quickly, he's included in a trial, but it's the only patient from abroad. All the other patients are from Germany, of course they're quicker there, or France and Spain. But there is, these trials are so expensive, controlled trials are really expensive. And this Biden trial was only possible by the help of ILA International. They supported this trial, and they give the money to run the trial, so they get the money back if the trial is successful. That's the deal, But usually you need millions of euros to run such a trial. And that's kind of a problem for rare diseases, where you can get not very much profit after the drug is approved,
Yeah, well, that's not true though, is it, Wolfgang? They expect to make just as much profit as they do from a blockbuster. That's the problem. The company expects to make just as much profit from selling a drug for a rare disease as it does for a very common disease, and the result of that is it is incredibly expensive.
Yeah.
We could have a whole other meeting about whether pharma is fit for purpose, but we probably won't do that. I think we've done our allotted time, unless there's anyone who really wants to ask anything, and I'm going,
It's more on a bigger level, I'm asking about the neonatal screening. You know, as a group, is there anything we could be doing to support the cause?
Not listening off the hook, is it?
I thought he'd escaped.
Sarah has been doing sterling. Yes, you could go next door and look at those consent forms for us. Yeah, that would be very, very helpful. But basically, Sarah's been doing stunning work with the Newborn Screening Committee, talking to all the right people very persistently. And I think, we hope, we're crossing our fingers and toes, but we think she's gradually winning that war, as long as we write the documents right. And so all the professionals got together at the end of yesterday and talked for over an hour about the exact arguments that we're going to use and some arguments we're not going to use. So we've had a big debate as to whether we would want the newborn screening to be done on all babies, male and female. Actually, kind of yes, we would, but we don't think